Hey friends, the views of our guests do not necessarily reflect the views of Let's Talk Menopause. Let's Talk Menopause does not provide medical advice. The content in this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions that you may have. This episode of Hello Menopause is sponsored by Versally. Visit Versally.com for the info and products you need and the menopause care you've been searching for.
Heart disease is the number one killer of women. It's not breast cancer, which is what many people think. You are at your greatest risk, maybe your peak, when you are in full menopause, especially if you haven't done anything during perimenopause, meaning preventive care, to keep you from going there.
Welcome to Hello Menopause. I'm your host, Stacy London. Hello Menopause is changing the conversation around menopause. In every episode, we explore the physical, emotional, and mental changes that women experience during this transformative stage of life. In this episode, Dr. Jayne Morgan joins us to make the case that menopause is one of the biggest cardiovascular events of a woman's life. Please welcome Dr. Jayne Morgan to Hello Menopause. Welcome to Hello Menopause. I'm so happy you could join me here.
Stacy, it's great to see you again. I have missed you.
I missed you too. And God, we met a year and a half ago, I think at Tamsin Fidel's, the hottest menopause project.
Tamsin's, that's right.
Yeah. And I sat next to you at dinner and I couldn't believe how lucky I was. I was like, you are an expert in cardiovascular health. There is nothing more important to talk about. Oh my God, tell me everything, right? And I know that you have said that menopause is almost an inflection point for cardiovascular health. And I'd love to start with that and to talk to us a little bit about what you mean by that and really, how this conversation has become part of the forefront of the entire menopause conversation.
And you know what, Stacy, I enjoyed sitting next to you as well. I felt so lucky. You were so interesting. I was like, oh my God, it was Stacy London.
We're both glad, right? Tamsin's seating arrangement was wonderful.
Right. She had a great seating arrangement. She did. She takes care of every little detail.
She really
does. Tell you, it was interesting. I posted maybe, I don't know, a few months ago, ChatGPT said about me when I entered, it said, Dr. Jayne Morgan is repositioning menopause as a cardiovascular inflection point and not a gynecologic footnote.
Yeah.
So ChatGPT, totally encompassed that for me several months ago. So I always hold on to that quote from ChatGPT.
Wow. About Dr. Jayne Morgan. I think that's fascinating. I have to say,
fascinating.
Yeah, we all know about the, rise in AI and how that's going to affect us. But it is really interesting when you can read something about yourself where they've encompassed all of this information in a way that's very digestible. So you can't argue that AI is going to be wonderful in some ways. Right. It's really going to help us. And I do think that that's true. You talk about it as an inflection point rather than a gynecological footnote, which we should address, has been the issue for years and years, right? And I say that our generation, Gen X, has really sort of taken, menopause by the neck and said, wait, hang on a second. We really need to explain this. We really need to understand more about female physiology, what is happening to us at this stage, particularly with our heart. And can you tell us what you think leading up to menopause or the menopause experience that we should be thinking about in terms of cardiovascular health, and then post-menopause?
Right.
How does that change for us?
A woman's cardiovascular health, really starts with so many life phases. And so let's just start with pregnancy. And so pregnancy complications are not benign. And the way we usually manage them, I want to say used to, I'm afraid to say used to because I'm hoping we're still not doing it somewhere. But I would just say the way we were taught to manage pregnancy complications, you have a high risk OB come in to manage the patient, but by and large, it's still managed from an obstetrical and gynecologic lens. All other physicians, we all work in our specialty silos. And so the treatment for pregnancy complications like preeclampsia or high blood pressure or eclampsia or even gestational diabetes was actually to deliver the baby, because we noted that once the baby was delivered, the mother's indices, her parameters kind of gradually came back down to normal. So we would say, okay, all we need to do, get the high risk OB in, keep mom and baby safe, as long as possible through this pregnancy, get her as close to term, deliver the baby, and that's a win. But we now know that is not true. That's really just the beginning. That pregnancy was a marker, her pregnancy complications of heart disease. That this woman's risk of heart disease now is going to be twice that of someone else's.
Wow.
Yeah. And I want to be clear about something because I get asked these questions. And, it's always surprising how people kind of interpret what you're saying. So I want to be clear on this.
Yes.
I've heard people say very cleverly, well, you know what? I'm going to avoid that. And I don't have to worry about pregnancy complications and heart disease. I'm just not going to get pregnant.
So, okay.
Yes. So, okay. So I want to be clear. It's not the pregnancy that causes the heart disease. The pregnancy actually did you a favor by declaring it for you. It identified which women are more susceptible. So even without the pregnancy, you still would have been in this high risk group. You just wouldn't have known it.
And is this similar to, people who don't experience symptoms during menopause, or perimenopause, right? They don't get hot flashes and they don't have the foggy mind or the joint pain or the brain fog, whatever it is. That doesn't mean they're not at risk for things that happen as we age, right? Like cardiovascular health, osteoporosis, all of the things that become sort of markers for us to pay attention to post-menopause, right? So I really love the way that you phrase this, is that you can be non-symptomatic, right? When you have a pregnancy that does not appear high risk, but it does mean that there are potentially issues that you may find after pregnancy that were determined by not by being pregnant, but by the results that shows you.
That's right. And it's not normal pregnancies. I'm talking about pregnancies that have complications, which is a high percentage of our pregnancies here in the United States. I mean, this is not, just sort of a tiny, tiny number of people. We don't have to think about it. No, this is a large number. And we have the highest, maternal mortality rate in the world. So women are still dying.
Yes.
And most of those deaths are cardiovascular deaths. And so I'm talking about the women who survive it. And it's sort of the system saved you, everything's fine. But no, your risk of heart disease is still elevated. So the reason the pregnancy helps to declare it is because the pregnancy is a stress test for the system. So here's why it's important for doctors to come out of our silos. So an OBGYN sees a pregnant patient with complications. They may say, 36-year-old female in her 32nd week of gestation with preeclampsia. And a cardiologist comes and looks at the same woman and says, 36-year-old female in a volume overloaded state who's just failed her stress test. You see, same patient, two separate lenses, diversity of thought, diversity of experience, diversity of perspectives brings that whole picture now in for that patient. The cardiologist is not looking at a pregnancy. The cardiologist is saying, well, that is a volume overload. And what happened with the volume overload? That the vasculature of the woman was not able to manage that. And so that stress test, that is a failed stress test. And it's an indication of inadequate vascular supply in a woman. And it's also true if you've ever had a low birth weight baby. If you've been told that your baby was small when it was born, you might have said, yay, that's great. I didn't have to deliver a big baby. Love that. Perfect. But the fact of the matter is small babies mean that there was some compromise in the vascular supply, the blood and oxygen supply to that woman. Even though the baby's perfectly normal, perfectly well-formed, didn't grow as large as we expected because of that blood supply. So low birth weight babies are also indicators of women who are at higher risk of heart disease. So
I knew none of this. And I'm so curious. Dr. Morgan, do you get referred a lot of high risk pregnancies? Are you sort of being asked to consult on those kinds of cases? Because it does seem to me the way that you're describing this, a cardiovascular expert should really be part of a pregnancy team. If you're not on the team. Right?
If you're not cardio obstetrics teams, people shouldn't live in silos, work in silos, and then, the cardiologist only comes in when there's a problem. Oftentimes that problem is a code. The mother may be coding. the baby may be coding. That's not the time to have a cardiologist involved. But as a whole, medicine hasn't understood the lens that I'm bringing you as a cardiologist. They're
Yes.
looking at the lens from a gynecologist. And once you deliver the baby, a lot of those indices return to normal and everybody forgets about it.
Exactly. And what I think is so interesting is it also does put the focus on the mother, right? Just for all of these conversations that we're having around birth and around abortion and what's legal and what's not, there is this conversation that keeps happening about, how every fetus is a life, and yet nobody seems to care about the woman carrying this fetus. This also puts an emphasis on her health as opposed to just the health of the child.
Yeah.
It's
And
an incredibly important conversation.
it is, because heart disease is the number one killer of women. It's not breast cancer, which is what many people think. And the other thing I want to correct you, I don't consult on any patients. So I am the vice president of medical affairs at Hello Hearts, the digital first AI forward cardiovascular company. We have a blood pressure cuff monitor, Bluetooth enabled app. Why? Because blood pressure is the single biggest driver of heart disease. And we see elevated blood pressure in these pregnancy complications, and we certainly see it in perimenopause and menopause. And we are trying to drive these numbers down, pull women back from the starting line of this heart disease. And so that's where I work. So I am not seeing patients. I'm full-time engaged in a digital AI space, but also in education and public health, and making certain that people understand it.
I just want to get to one of my other questions before I forget. We talked about this a little bit, and I am curious if you're seeing if there's a specific window, perimenopause or postmenopause, where the cardiovascular risk is greatest, or at least where the risk changes are most dramatic.
Right. So the risk changes are most dramatic when you look at the age of 51. When you get to the age of 51, this is where we start to see, remember, I'm working at a blood pressure company, a cardiovascular disease management company. At the age of 51 in women, which is the average age of menopause, more or less, of females in the US, you see a dramatic increase in blood pressure. Prior to that, when we look at both lines, say of men and women, men have higher blood pressures throughout the entire lifespan. We're talking 10 years old, all the way up to 50. The men's line is up here, the woman's line is down here. And then suddenly at 51, even though men go up slightly, women take a sharp increase. And now our line is on top of the men's line. So that is an incredibly important inflection point and time when we talk about the loss of estrogen, the loss of vascular pliability or flexibility, the rigidity now
when we see 51 is we see the loss of estrogen, and we see cardiovascular.
We see the blood pressure going up. That's right.
And are those two things related to each other?
They are related.
Estrogen creates higher blood pressure?
That's right. Direct correlation.
Wow.
Estrogen is what, by and large, protects the hearts of women and protects our vasculature as well. When I say vasculature, I mean our arteries and our veins. And these things are important to manage your blood pressure. And so when we look at that graph, it's very, stark to see how these lines suddenly switch.
Yes.
And the women are on top and the men are on bottom. And that is directly related to menopause. So you are at your greatest risk, maybe your peak, when you are in full menopause, especially if you haven't done anything during perimenopause, meaning preventive care, to keep you from going there. Now, perimenopause is your greatest interventional opportunity window, right? There's a window to just jump in with both feet and take care of it.
All right, but how do we do that, right? Like really, if we are being, masters of our own fate here, and we are really trying to think about all of the ramifications that happen with this loss of estrogen,
That's
right? Forget about even just saying it's menopause or whatever. We know that our blood pressure tends to go up after 51 if you are female. What can we do? And how
it goes up significantly. It's not a gradual rise.
Right.
It is a metabolic cliff that we fall off of. That's what happens.
Right.
So if we can back up to all those years prior and pull ourselves back from that cliff where we suddenly take a steep rise up above men, our blood pressure is rising. That's loss of estrogen. And, we talk about estrogen and hormone replacement therapy. That's what we're talking about. Improving your vascular biology. And in improving your vascular biology, meaning lowering your blood pressure and making your endothelium, the vessels, the lining inside of your vessels, healthier, it decreases your risk of heart disease. So I hear a lot of people say, well, there's really no data on primary nor secondary prevention of heart disease on estrogen or hormone replacement therapy. Well, there are a lot of reasons for that. One, women haven't been included in trials. Two, on and on about research and what's happening in the patriarchy of medicine. However, let's pull away from that and say, okay, that's true. If we want to do that, if we want to look at these randomized clinical trials and there are other things to think about, but I want to just stay on this train of thought. If we were to look at that, then let's talk about risk factors then for heart disease. Hypertension is the most significant risk factor. There is no argument that estrogen positively impacts the endothelial lining of arteries and makes them more pliable to bring blood pressure down. So even though we don't have studies on the primary and secondary prevention of heart disease, we've got studies on the prevention of high blood pressure, which is a risk factor for heart disease, right?
Well, it's really interesting that you say that, right? Because we are so concerned with the fact that there isn't enough research. It's certainly not enough research about female physiology specifically, right? We're not little men, and we've been taking all of our cues from what, we've discovered about male physiology. And I think that menopause being so singular to the female form, it just opened up the fact that there is such a health gap. There is such a gap in terms of information. And most people, as you say, don't even know that heart disease is the number one killer of women. We assume that it's breast cancer or ovarian cancer or something related to female organs. But I am so fascinated by the fact that this has allowed me to understand how little care women are actually receiving, right? How little we understand, or we can say that we can prove about what's going on with women. So do you find that these they're not correlative tests, right? They're not one-to-one, but these things where you can discern and determine that estrogen helps with loss of blood pressure, that it's okay to make that assumption that cardiac health will then be affected, right? You don't really need the test to prove the point.
Yeah, we always like to have endpoints in research that we're actually measuring. So if we are going to say that it reduces heart disease, we want to have a trial where the endpoint was heart disease reduction or a decrease in heart attacks or decrease in stroke or something. We don't have that. What we do have is the positive impact on the single biggest risk factor for heart disease. So we can make that implication that if it is improving the biggest risk factor for heart disease, it must be improving heart disease. So we are making that implication that this is a recognized risk factor for heart disease. Estrogen improves that risk factor. So therefore, it decreases your risk of heart disease. And here's why I will also say that. For every 10 millimeters of mercury that your blood pressure goes up, your risk of heart disease goes up by 20.
Wow.
So if your blood pressure goes up by 20, systolic, that top number, your risk of heart disease goes up by 40%. So if you are able to lower your blood pressure and keep your vessels low, we already know then that you have lowered the percentage of heart disease just by how many millimeters of mercury you've been able to lower your blood pressure. So no, we don't have studies, and yet we do have studies.
Right. Exactly. This is where your expertise becomes essential in kind of pulling these strands apart. And I'm curious if there are particular symptoms that, women as they are in perimenopause or postmenopause are still experiencing that they may chalk up to menopause that might have a more serious cardiovascular diagnosis.
You said at the very beginning of the podcast that, some women who've never had any symptoms at all. I tell you, I only know one, and I like to say she claims that she's had no symptoms. There are so many symptoms.
Right.
And I think women are completely unaware that some of these symptoms are actually perimenopause. So, I would say the one person who's told me that she's never had any symptoms, then I would say she likely has had some things that just haven't been bothersome. They haven't been
Right.
burdensome. She's adjusted. It hasn't been a big deal. Maybe she attributed it to getting older. I would say you have nothing that you recognized was
Wow.
actually a perimenopausal symptom, but you probably had something. I'm always fascinated, and I check in with her from time to time. So tell me.
Yeah. How are you feeling? How's it going? Are you still like happy, cheery, go lucky?
Yeah.
I honestly, I can't imagine it, right? Having had such a difficult perimenopause experience, I'm like,
Right.
what is it like to be
And I will
symptom?
say this for her, we're talking about medications. I want to talk about nutrition and exercise.
Yes.
Big, huge, huge factors. I'm not here just pushing medications and things. I want to talk about nutrition. I want to talk about sleep. I want to emphasize exercise. And this person in particular, who says she's never had any menopausal symptoms, she is perimenopausal symptoms. She is kind of like a nutrition exercise fanatic on overload. And I say that to say, if this is the effort that is required to avoid perimenopausal symptoms, like 99.9% of people would not be able to achieve this level, right? This is not normal. And this is not something, it's more on the extreme end. So it's interesting because I do track her that, oh my gosh, it just goes to show you, is perimenopause such a foe that the only person to not have symptoms would be someone who's on such the extreme end of nutrition and fitness. Like, this is literally her whole life. Her life is this. We don't have 8 hours a day to spend on it.
I'm also curious, is there any symptoms that you see in perimenopausal women that make you think there's a cardiovascular issue there?
First of all, all of them make me think of cardiovascular issue, including painful sex, including urinary tract infections, including, whatever, metal taste in your mouth or itchy ears. And I'll tell you why, because they are all markers of decreasing estrogen. And that means that we're losing the protection of estrogen on our heart. So every single symptom is an indicator to me that I need to take care of this woman's heart, and began really aggressive preventive measures, because she now is stating that, she's having increased clumsiness, or she's having bone pain, or whatever, decreased hearing, it's any number of things. And, for the first time, maybe sexual history is part of your cardiovascular history. Maybe talking about painful sex is something that needs to be a discussion with the cardiologist. So the cardiologist knows, I need to check her blood pressure and her cholesterol, her sleep, and her, right?
Yes.
And her weight and her visceral fat, because this is an indicator that I need to get on top of this, because her risk of heart disease is increasing. That's how we need to reframe that.
That's how we need to reframe. And I'm wondering, when you see something like that, what is the standard response? I'm recognizing, just as women, we absolutely have to pay more attention to our cardiovascular health. But when you say preventative measures, does that mean putting somebody on HRT? Does that mean putting somebody on a statin? How do you decide what the best course of action is going to be for any?
So when I say preventative measures, I'm not talking about HRT. I'm talking about risk factors for heart disease, and loss of estrogen is a risk factor. But now I'm talking about the results of that loss of estrogen. Blood pressure has gone up. Get on medications. Let's bring it back down. Your cholesterol has gone up. Get on medication, statins. Bring that blood pressure back down. Your sleep has been disrupted. What can we do to try to get you back into good sleep? Because when we talk about brain fog, that has a lot to do with your sleep debt over time, and the inability now to process executive functions because you're so sleep deprived. You have 1 or 2 years of sleep debt, but you're supposed to be functioning at a high level. And so brain fog, I think, has a lot to do with not addressing that women don't sleep for 3 years. And then we're like, I don't know why I can't think. I don't know why I can't process information. You haven't been asleep since, 2023.
Exactly. There's a couple of things here that I think are so important, right? There's like one, we actually need to understand what the 10 poles are for good heart health, period, throughout our lives, right? Especially if we're getting indications as early as pregnancy that we may be at higher risk for heart disease. So that seems very important to me. And I'm curious, like when you talk about 10 poles just for heart health, are we talking about sleep, nutrition, and exercise?
I think when we talk about the tent poles, we're talking about hypertension, cholesterol, diabetes, obesity, probably anemia is probably one of the ones that we're overlooking, and vitamin D deficiency. I would say those are probably the top three: hypertension, cholesterol, diabetes. Insulin resistance is a result of estrogen loss. And so we have an increased risk of diabetes. Diabetes is a risk factor for heart disease. High cholesterol is a risk factor for heart disease. Hypertension is a risk factor for heart disease. Sleep duration or lack thereof, risk factor for heart disease. Obesity, weight gain, risk factor for heart disease. Yeah.
Yeah. You addressed it differently by saying these are the things that if they're abnormal, we know we're in trouble, right? The things that are preventative care for high blood pressure, like just what you were saying, take the drug if you need to get your blood pressure down or your cholesterol down. Get the sleep or figure out how to reform the sleep, right? Think about nutrition where where you don't have vitamin deficiencies in a way that allows us to maintain a certain level of health throughout our lives that eventually, hopefully, is protective against vascular disease. What do we do if it runs in our family?
Genetics are interesting because we used to think, well, genetics are just your fate. But genetics are not necessarily your fate. We can impact oftentimes our genetic DNA with our behavior choices, with our food choices. It doesn't mean that you may not get the disease, but you actually may be able to delay it for a few years later. May be able to get it later. You may be able to get it in a milder form because you're making different choices about your health and how you're going to manage your health. So genetics is not, that's it. Nothing I can do about it. Mom had it, dad had it. Screw it. I'm just going to drink this vodka every night because there's nothing I can do about it. No, it actually is something you can do about it because you may not be able to prevent it from happening, but you can decrease the intensity. You can decrease the severity. You can delay the onset of when it starts. When it starts, you can delay the progression. So it's a slower progression. Lots of things you can do to impact. It's not just genetics, it's how the environment interacts with the genetics.
Yeah.
And that's the part.
And it's interesting, you're even saying in your behavior. I really do think there's something so wonderful when you are sort of taking your health into your own hands. When you're using your agency and making positive choices, they sort of reinforce one another. And it's interesting because heart health is something that perimenopause is the perfect kind of last ditch opportunity to really get your heart health, in good stead. But it is the type of thing that we can really practice our whole lives and see that additive benefit by the time we get to menopause, right? So we actually can affect at every stage of our lives and at least get in there and do something better for our health than, saying it's all up to our genetics. It's up to fate. I'll see how it happens. That there's a lot that we can do before and after the menopausal experience to really take care of our heart health.
That's right. We can be our own best AI agents. We absolutely can.
I love that.
Yeah. And you want to live the life today that you see for yourself tomorrow or 10 years from now. Look in the mirror and say, what kind of life do I want for this person 10 years from now? Those are the decisions you have to make today for that life that you want.
There's a couple of questions I have about that. I mean, one, I think it is hard for people, some people, not all people. Me personally, if you tell me do this today because it's going to benefit you in 10 years, I'm like, 10 years, that feels like a long time. I can't worry about that. I'm going to eat the cookie because that's 10 years from now. I'll get it together before 10 years.
Have a cookie.
Right.
Deprive yourself of cookies forever. Don't eat the whole box. Cookie. Right.
Have a cookie.
So moderation. And eating is part of pleasure. But we're talking about perimenopause and risk factors for heart disease. It doesn't mean that you now have to become a nun and you have the most, restrictive life ever. You can certainly have, a cookie. I just want to make that point.
Yes, of course. And I'm sort of teasing, but I do think
Right.
that there are a lot of us that find that, oh, this will benefit us in 10, 20 years to not be motivational, right? It's like, well, how do you kind of keep it in the here and now? There's a benefit to it now, as well as the additive benefit of like taking care of yourself. By the time you're 51,
Yeah.
you're going to
Yeah.
be in a much better position.
Sure. I mean, and obviously the benefit now is, especially if you're taking care of your blood pressure and your cholesterol and your weight and your nutrition and your sleep is better energy. You are more of a whole person and you're
Yes.
feeling good. So what are we talking about now? Quality of life.
Yes.
So your quality of life measures increase. And the bonus is it's going to help you 10 years from now. You're feeling good now. 10 years from now, you're going to be a little better than if you had not been doing it. So there are some benefits to it. Now, it takes work. That's why a lot of people don't do it, right?
Yeah.
People don't want to exercise. People don't want to move. People don't want to eat just one cookie. People don't want to eat, like, all of that requires.
All of these people. I'm the one who doesn't want to run. I'm the one who wants to eat all the cookies. But, but I wonder, we're talking about something that not just requires agency, but does require communication between physicians, right? You talk about this idea of how the perspective changes on somebody's health when it's a cardiologist looking at somebody's, health, or a gynecologist.
Right.
One, is there a future vision in which we can kind of see doctors being able to work in teams like that when it comes to a patient?
I hope so. I write about it all the time. I was also on the cover of Atlanta Medicine magazine, which is our medical journal. I should see if I have a copy. I should have brought a copy. Yes. It is the first journal, a medical journal that was devoted entirely to menopause. So I recruited all of the physicians who wrote. They were all in the state of Georgia. Everyone submitted articles, including myself, 2 articles, 2 journals, and we had an entire issue that was just focused on menopause. And all of these doctors were from different specialties. So we are starting to get that message out there. One of the articles that I wrote was specifically on all of the doctors coming out of their specialties. And if you follow me on social media, I do something called the Stairwell Chronicles. I sit on my stairs and talk. The last few, if you go through, I'm sitting on my stairs. I have my laptop on my lap, and I'm typing letters to every single specialty, telling them how menopause is their responsibility. I talk to cardiologists. I talk to the primary care physician. I talk to dentists. You can go through my social media and listen to every letter that I have typed to all of these. I do it out loud. I write the letter right there on social media to the specialties, explaining how menopause is their responsibility.
Tell everybody right now where to find you.
Yeah, it's Dr. Jayne Morgan, Dr. Jayne. There's a Y in my first name, JayneMorgan on Instagram. Also, I'm on Threads, I'm on TikTok, and on LinkedIn as well. And LinkedIn is Jayne Morgan, MD. So use my name, Dr. Jayne on Instagram. If you go on to Stacy's, you can see I'm connected with her. If you
Absolutely.
Find me.
And, the other thing I was going to ask you, Dr. Jayne, is like, it's one thing to talk about all of this and to write to all of the different specialties, that really need to be involved in menopause. But what do we do about sort of health inequity and inequality, not just for women, but then you look at women, and women of color are so disproportionately affected by not having resources, not having doctors, not even having enough hospitals. Right. How do we even begin to approach this? I mean,
and I have been working on that as well, and thinking, because Black women in particular have the longest and most severe perimenopausal symptoms. And I think that is because of the debt load of stress that we carry and then bring into perimenopause. And perimenopause is not anyone's friend. And the greater your stress and the greater your debt load of stress over time, cumulative, the worse your perimenopausal symptoms will be. And we see Black women having the longest stretch, which is sometimes 10 years or more.
Yeah. And I also think this is true of pregnancy, right? I mean, maternal mortality rates are 3 times in Black women that they are in other nationalities and races. This, to me, is one of the most upsetting things that I did not even realize until being in the menopause space, that it's not just like women are being ignored. It's literally that there is a class system that is truly based on resources. That's all our medical system is. How do we help each other?
Interesting, because Black women that were not born here in the United States do not have the same high rates of maternal mortality. It's only Black women who are born in the United States of America. So it's inherent to being here in this country and having the lived experience here, and it impacts pregnancies. And when we talk about epigenetics, it impacts then generations later, the milieu under which the fetus is being formed, and what's the situation of the mother. So yeah, it just kind of goes on and on. So I think about it a lot. Stacy, thank you for asking. I do think about it.
I know you do. And I'm always looking for ways in which that we can equality in care, even if that's just information. It's one of the things that we try to do on the show, just so you don't have to have money to get answers from smart people who know what they're talking about. That was really actually the goal when we decided to do the podcast. Every podcast we suggest 3 action items that people can do on their own that will either help them through their menopausal experience or help them take better care of their health. What are the things that you would recommend to people who are listening?
Yeah, I would say number 1, if you're prescribed medications, take your medications, right? Don't have bragging rights of, I don't take any meds, because it makes you feel old to take medications and you like saying you don't take medications. No, take your medications, because you're just playing with fire.
Right.
And you've got to get these risk factors down. So number 1, take your medications and feel privileged and lucky to have actually been in a health system where you got prescribed something, because many people are not being prescribed medications. So number 1, I want you to take your medications. Number 2, I would say, engage more with AI as it continues to accelerate, because here's where we're going to be able to get answers. And I will say right here on your podcast, it's going to be women's health that's going to drive AI and a digital form of research, because we are the ones who need it. We will be the first to adopt, demand, and make it a standard of care, because we're not going to wait another 25 years for research. So AI can be your friend, and embrace it for perimenopause. And number 3, follow me on social media. I talk about it all the time. You're getting just good information from someone who's just, shooting straight from the hip. Send me questions. I'll answer the questions. It's Dr. Jayne Morgan, JayneMorgan. Follow good people on social media, not people who have a hook to get you there, or they've, you need to buy something, you need to sell, whatever it is. Follow good people who are actually giving you good information.
Excellent advice. Thank you so much. And we will all be following you, because I really do feel like you do shoot straight from the hip, but also you care so much. And I just feel like there's something wonderful about the fact that this conversation about menopause has brought so many kind, caring people to the forefront. Essentially, that we don't have to be afraid of our own health if we have people like you kind of leading the way for us. And really, the fact that cardiovascular is such a big part of the menopause experience that I don't feel like most people know.
Well, ChatGPT said Dr. Jayne Morgan knows this. This is what she's doing. I was shocked.
Thank you so much for joining us.
So much, Stacy.
Hello Menopause is a production from Let's Talk Menopause, produced in partnership with Studio Kairos. I'm your host, Stacy London. Let's Talk Menopause is a national nonprofit organization invested in changing the conversation around menopause so women get the information they need and the health care they deserve. Please visit letstalkmenopause.org. Hello Menopause is available on YouTube, Spotify, Apple, and everywhere you get your podcasts. This episode of Hello Menopause is sponsored by Versely. Visit Versely.com for the info and products you need and the menopause care you've been searching for.